Thanks very much, Eric. Before digging into the Healthy Michigan plan, I thought it might be beneficial to give a little primer on the context of this expansion of insurance we've had in our state. In 1965, Medicaid, along with Medicare, was enacted and added to the Social Security Act as a program to provide health insurance to categorically needy individuals, such as the blind, disabled, and low-income families with dependent children. Medicaid was designed as a joint endeavor between the federal government and state governments. The federal government sets standards, and then state governments have flexibility to design programs that best meet the needs of citizens in those states. Michigan began its Medicaid program in 1966. Over the past 50 years, Medicaid in Michigan has grown in scope and in enrollment. There are currently roughly 2.4 million Medicaid beneficiaries in Michigan. These have traditionally been low-income children, the elderly, and the disabled. Medicaid is the largest source of long-term care for Michiganders, and coverage for 46% of all births in Michigan is provided by Medicaid. The Medicaid program had an initial expenditure of $150 million in fiscal year 1968. That has now grown to $16.9 billion. There are a few major factors that drive this growth: the ever-increasing cost of healthcare services, an increase in the number of eligible beneficiaries, and the creation of new eligible groups, such as the Children's Health Insurance Program or the Healthy Michigan Plan, and the expansion of types of services covered by Medicaid. A small amount of this Medicaid spending growth may also be explained by previously separate state services being absorbed into and provided by the Medicaid program. When we look at this cost figure of $16.9 billion, it's important to understand the types of services that this pays for. Roughly 40% of this spending goes into what I would consider subsidization of the Medicare program. So that's providing either long-term care for elderly individuals, which isn't provided by Medicare, or providing assistance with Medicare premiums or other coverage for low-income elderly adults. Another 20% of program spending goes toward helping disabled individuals. That roughly rounded up is about 2/3 of program spending. A large number of Medicaid beneficiaries are children, but because children are inexpensive to insure, that amounts to about 20% of the cost. And so the final 20% of cost is for low-income adults and families. When we look at the share of Medicaid spending between the federal government and state governments, we see that on average, states pay for about 37% of their Medicaid programs, whereas the federal government pays for 63%. In Michigan, we receive a higher share of federal funding. Nearly 3/4 of our Medicaid program is paid for by the federal government. Michigan's fiscal year 2018 federal medical assistance percentage is 64.78. That means for every dollar state government spends on traditional Medicaid programs, the federal government matches that dollar with $1.84. Now you may note that the share of federal spending here is higher than Michigan's federal medical assistance percentage, and that's because programs like Healthy Michigan have a higher FMAP and so get enhanced federal matching money. Out of this total $16.9 billion in spending, the vast majority goes into managed care, a system of healthcare delivery that's meant to constrain costs, manage utilization, and maximize health outcomes. Many Medicaid beneficiaries get their health insurance managed by private health insurance plans who receive a capitated payment or per head, per enrollee payment each month. Other large drivers in spending are, as mentioned, long-term care as well as hospital services. It's now my pleasure to break the news that in 2010, a law was passed called the Patient Protection and Affordable Care Act, or ACA. You may not have heard of it, but I'm happy to tell you a little bit about it. There were three primary reform mechanisms in the ACA, those being market reforms, establishment of new marketplaces, and the aforementioned Medicaid expansion. Among the market reforms, possibly the most popular is guaranteed issue. That means that insurance companies have to provide health insurance to individuals regardless of any pre-existing health conditions or the overall health status of the individual seeking to purchase health insurance. This creates a delicate balancing act with probably the least popular of these market reforms, which is the individual mandate, meaning that people have to purchase health insurance or else face a tax penalty. The reason I say these two are a balancing act is that it's difficult to mandate that an insurance company must provide someone coverage without also mandating that those people need to purchase health insurance before they become sick. Without the individual mandate, guaranteed issue would look like allowing individuals to purchase car insurance after they've wrecked their car, or house insurance after their house is burned down, expecting someone else to pay for the costs of replacement. Shared responsibility provisions for employers were also contained in the Affordable Care Act for employers with more than 50 full-time equivalent employees. Other key benefits include the identified 10 essential health benefits, restrictions on annual or lifetime limits, the elimination of cost sharing for preventative services to encourage people to improve their health through prevention, and extending dependent coverage to individuals up to age 26 so that they can remain on their parents' health insurance plans. Among the new marketplaces established in the Affordable Care Act, 321,451 enrolled in private plans through Michigan's exchange during the 2017 open enrollment. By contrast, in the small business marketplace that was established by the Affordable Care Act, there were only 294 active employers and 1,802 employees covered by Michigan's federally facilitated shop exchange in January of 2017. This is a fairly low number owing to many small businesses eschewing this option under the Affordable Care Act and most likely going through other insurance brokers rather than opting through the small business exchange. It would be difficult to say that the small business exchange has been anything but a failure or a flop. Finally, Medicaid expansion was part of the Affordable Care Act. And a key thing about Medicaid expansion is that due to the NFIB versus Sebelius Supreme Court decision, this was rendered optional rather than mandatory. Here we've shown you a map of the current status of Medicaid expansion among various states. 32 states, as well as the District of Columbia, have expanded Medicaid to date. 7 of those states, including us here in Michigan, used Section 1115 demonstration waivers. These waivers are offered by the federal government to allow states to do different or innovative things with their Medicaid programs that might not be allowed under traditional rules for the program, encouraging state innovation. We'll discuss Michigan's waiver later in this presentation. That leaves 18 states that have not yet expanded Medicaid. It's interesting to note that just last month, Maine became the first state to expand its Medicaid program via public referendum. I would expect that Utah and Idaho are states to watch to possibly follow this approach. Virginia as well, due to the makeup of legislature and the executive branch and the governor's office, may be another state to watch for future Medicaid expansion. Since the passage of the Affordable Care Act, the change in the number of uninsured persons in the United States has dropped precipitously. Initial drop-offs were observed, but the major reduction in the number of uninsured occurs in 2014, which is both when the exchanges opened as well as when Medicaid was expanded in Michigan and other states. Despite this expansion of public insurance through Medicaid, the majority in Michigan still receive their insurance through employer-sponsored plans. Medicaid accounts for roughly 19% and Medicare 16% of insurance in Michigan. These numbers are from the Kaiser Family Foundation. It's important to note that under the pie slice occupied by Medicare, there are dual eligible individuals, as I mentioned earlier, who receive supplemental coverage from Medicaid as well as Medicare. And so roughly 1 out of every 4 people in Michigan receives some level or some type of insurance through the Medicaid program. Now let's talk about Michigan's Medicaid expansion, the Healthy Michigan Plan. The plan was signed by Governor Snyder in 2013, and implementation began in April of 2014, a few months late, but I guess, as they say, better late than never. The Healthy Michigan Plan predominantly expanded adult eligibility, especially childless adults. Some of these childless adults were previously covered by the adult benefits waiver, but by expanding that program up to 138% of the federal poverty level as an income threshold, many new childless adults were able to receive health insurance coverage. This expansion of coverage also affected low-income parents, as well as 19 to 20-year-olds, and even some medically fragile individuals who are disabled. Enrollment in the Healthy Michigan Plan stood at 665,057 enrollees. That's as of yesterday. These are updated numbers from a report. The program surpassed its first-year enrollment goal of 322,000 within the first 100 days. 46% of enrollees in the Healthy Michigan Plan are between 19 to 34 in age. This is important to note because across the United States, younger individuals in this 19 to 34 age range typically have the highest rates of uninsurance and also statistically have the lowest household incomes and are least able to purchase health insurance plans on their own. Enrollment isn't the only metric of success, however. Access is highly important, and we can try to measure access by a variety of different metrics. One of those is individuals having a usual source of care. We've seen that under Medicaid expansion. Medicaid expansion has also facilitated more individuals accessing preventative healthcare services. Of the 348,236 individuals who were on the Healthy Michigan Plan for at least 11 of the 12 months in fiscal year 2016, around 3 out of 4, 73.95% for those who are keeping track, utilized at least one service that was categorized as preventative. A total of 1,324,754 claims were categorized as preventative for the total population of the Healthy Michigan Plan enrollees during fiscal year 2016. Primary care appointment availability is a more useful measure of access. One fear expressed prior to implementation of the Healthy Michigan Plan was that there would not be available capacity among medical providers to treat a sudden influx of newly insured individuals. Fortunately, this problem has not materialized. Some academic studies measuring appointment availability have found that availability of primary care services and appointments have actually increased since implementation of Medicaid expansion. One possible explanation from this is a greater reliance on primary care provided by non-physician practitioners, meaning either nurse practitioners or physician's assistants. And previous research done by the Citizens Research Council of Michigan found high patient satisfaction and high levels of health outcomes from care provided by NPPs. Another worry prior to implementation of the Healthy Michigan Plan was that expanded coverage for the newly insured population would impair access for those who are already continuously insured, either through private employer-sponsored insurance, Medicare, or Medicaid. These fears have also not been realized, and access for the continually insured has not been impacted by any negative spillover resulting from coverage gains through the Affordable Care Act, including Medicaid expansion. So on measures of access, Healthy Michigan Plan beneficiaries are more likely to have a usual source of care, have better appointment availability, have care that is more affordable, access and utilize more preventative health services, have better adherence to medication and treatment regimens, are using more ambulatory care visits as opposed to emergency rooms or hospital stays, and are accessing timely medical interventions. This chart shows eligible Medicaid beneficiaries by their enrollment group in December of 2016 in Michigan. And you can see that the Healthy Michigan Plan now accounts for roughly 1/4 of the total Medicaid pie. That benefit is spread relatively evenly throughout the state. Analyzing county-level beneficiary data for beneficiaries that were eligible for Healthy Michigan 11 out of the 12 months in 2016, the Citizens Research Council found that the average within urban counties was around 6.5% and just over 6% in rural counties. The urban average, it's worth pointing out, is skewed up by a full % by Wayne County, which has a high population and a large number of residents who are eligible for the Healthy Michigan Plan. It's also worth noting that in rural counties, there's a greater overall reliance on Medicaid, particularly among the disabled. What has been the financial and economic impact of the Healthy Michigan Plan Medicaid expansion? Well, it's certainly added a new layer of complexity and fiscal obligation to Michigan's array of Medicaid eligibility since its implementation in 2014. Spending on the Healthy Michigan Plan was approximately $3.6 billion in fiscal year 2016. This was before the state had borne any of the costs for the Healthy Michigan Plan. The Affordable Care Act established that the federal government would fully fund the cost of Medicaid expansions like the Healthy Michigan Plan through fiscal year 2016. States would begin to contribute greater shares of the cost over time. Our state liability began at 5% of the cost of the program in fiscal year 2017, and that will increase each year until the state contribution reaches 10% in fiscal year 2020. The remaining 90% will be paid by the federal government. And this is still much higher than Michigan's federal medical assistance percentage for other Medicaid eligible individuals. Once the state contribution has fully been phased in, the House Fiscal Agency estimates that the cost will be around $400 million per year to the state. Because Medicaid costs are partially funded through provider assessments and state retainers, about $222 million per year of this will need to come from the general fund in fiscal year 2021. Absent a proactive mechanism or plan to meet this funding obligation, the Healthy Michigan Plan will eventually join a host of other state spending priorities as a source of long-term fiscal stress. The Healthy Michigan Plan isn't only a source of costs, however, but also a source of savings. It has saved the state around $235 million per year in costs outside of Medicaid, such as non-Medicaid mental health costs at a savings of $168 million, the former Adult Benefits Waiver Program at a savings of $47 million, state prisoner healthcare costs at a savings of $19 million, as well as the Plan First Waiver Program, saving $1 million for the state. Numerous academic studies have found economic benefits that exist outside the state ledger, including adding of jobs, increased personal income, and a resulting increase in state revenue from this economic benefit, a multiplier effect. We've seen no negative workforce impact in Michigan from the Healthy Michigan Plan. We've witnessed a substantial reduction, over 1/2, of uncompensated care and bad debt among Michigan hospitals. And these types of benefits are consistent in all states that expanded Medicaid, not only Michigan. In talking about the cost of the Healthy Michigan Plan or of Medicaid to the state, it's important to consider the average cost per beneficiary. The Healthy Michigan Plan costs in 2014 were $505.94 per person. In 2015, the cost per member per month actually dropped by 0.5% to $503.38. Now that's not a big drop in costs, but any reduction over a year in health insurance is fairly unprecedented in our current environment. Rounding up, the 2016 cost per enrollee was around $504 per member per month. This makes Healthy Michigan Plan enrollees less expensive to insure than other Medicaid eligible individuals. Compared to private health insurance plans on the Affordable Care Act exchanges, this cost falls roughly in the middle. In 2017, marketplace silver plans ranged from a high of $1,133 per person per month, and that was a 55-plus-year-old individual who was a smoker in rating area 7, so Ingham, Eaton, Clinton, Jackson, and Hillsdale counties, to a low point of $183 per person per month, and that would be for a 25-year-old non-smoker in Oakland and Macomb counties. Among traditional Medicaid beneficiaries, the average cost per enrollee increased by about 50% from fiscal year 2001 through fiscal year 2016. In numbers, that's an increase from $4,900 per year to about $7,500 per year. This time span obviously predates the expansion of Medicaid. During the same time period, however, the cost of insurance for a family of 4 with employer-sponsored health insurance has grown by 300% to a cost of $25,826 per year. Using data from 2003 to 2009, an analysis by the Kaiser Commission on Medicaid and the Uninsured found that spending for adult Medicaid beneficiaries was 25% less than it would be per enrollee if they were insured through private employer-sponsored health insurance. So by our analysis, Medicaid expansion has been a fairly fiscally responsible way to provide insurance for its beneficiaries. Another important thing to consider in Healthy Michigan Plan is not only the costs, but what are the outcomes? What is it doing? For health insurance, we'd like to see some sort of health outcomes. One thing we do know is that acquisition of insurance facilitates better use of health screenings and preventative health services, leading to early treatment and providing important long-term health benefits. And we've seen a greater facilitation of health screenings and prevention through the Healthy Michigan Plan. Beyond these screenings for diabetes, hypertension, high cholesterol, the Healthy Michigan Plan beneficiaries can also access mammography, cancer screenings, mental health assessments, and other services to prevent, detect, and treat sometimes asymptomatic chronic conditions. The increased detection of chronic health conditions under Medicaid expansion may have important health implications long-term for both population health and state and national healthcare spending if it can lead to improved early management and control of these conditions. Some evidence shows that Medicaid expansion improves beneficiaries' awareness of management of high blood pressure as well as obesity awareness. In terms of this chronic condition management, however, as we mentioned, the Healthy Michigan Plan began implementation in April of 2014. And because these are complex health conditions that take time to manage, measuring those health outcomes is just going to take more time than we've had at this point. In terms of mental health, however, ample evidence is found for improvements in mental health and reductions in depression among Medicaid beneficiaries gaining insurance through Medicaid expansion. Depression is a leading cause of disability in the U.S., and it's also associated with the development of a variety of physical illnesses and conditions over time. This can range from psoriasis and osteoarthritis to diabetes and stroke. Managing depression has important implications for the health and well-being of individual patients. Depression management may also affect long-term healthcare utilization and spending, the prevalence of substance abuse and addiction, crime, and even workforce participation and productivity. Another metric of health outcome is self-reported health status, which is a reliable measure of general health that's widely accepted by researchers and scholars. Self-reported health status forms a proxy measure for objective measures of health, which are sometimes impractical or impossible to collect. And it offers us a way to make a meaningful metric and has predictive uses. For instance, those who self-report poor health have significantly higher mortality rates than those who report good health. Among Healthy Michigan beneficiaries in September of this year, 35.7% reported good health, 26.1% reported that their health was very good, and 11.5% reported excellent health. So only around a quarter of Healthy Michigan beneficiaries are now reporting either fair or poor health. And this is a good sign for us to estimate that there are health improvements happening. In addition to this much improved self-reported health status, low-income adults in Michigan and other Medicaid expansion states have reported better quality insurance coverage after expansion relative to before. As we mentioned previously, Michigan's expansion of Medicaid with the Healthy Michigan Plan was done with a Section 1115 demonstration waiver to introduce unique characteristics and innovations into the plan. These include cost sharing, a health risk assessment intended to incentivize healthy behaviors, recognition of the social determinants of health, as well as a sunset mechanism. Medicaid has traditionally imposed no cost sharing, as its beneficiaries were by definition poorer and sicker than the population receiving private insurance. Co-payments, co-insurance, and other cost-sharing mechanisms have been the subject of decades of study and debate, and some have argued that cost-sharing works to constrain costs and improve care by leading healthcare consumers to assess the relative value of the care they receive. Absent a shared cost, some may not value the care they receive, or, in a classic example of moral hazard, they might expose themselves to greater risk by over-consuming unnecessary or low-value healthcare services, which every healthcare service poses some degree of risk, and so unnecessary x-rays, unnecessary procedures, treatments, prescriptions can all worsen the health of individuals. This makes cost sharing a valuable economic tool to constrain or modify individual consumer behavior within the healthcare marketplace. Others might argue that an ideal copay can encourage high-value procedures and discourage low-value ones, but that copay should avoid restricting access to preventative care and screenings. Copays should be utilized strategically to improve healthcare consumption and behaviors. They shouldn't be blunt instruments. When a high copay, while it may be appropriate for certain medically unnecessary procedures or for procedures where there are lower cost alternatives, copays should be very low or non-existent for high-value drugs and services. And as we've mentioned before, the Affordable Care Act made preventative services free without copays. And within Medicaid expansion, we have no copayments for chronic condition management because we want people to manage those chronic conditions. There are others that might argue that healthcare is a right, not a commodity, and that any cost barriers to healthcare services are unjust. The fact that copayments affect individuals differently based on health status, age, socioeconomic position, race, gender, and other factors should be considered. With the copays that we have in the Healthy Michigan plan, there are two types of cost sharing. There are copayments for services or for the average number of services. These are applied to all beneficiaries. It's a fixed amount based on the frequency of utilization. And as I mentioned, no copays for chronic conditions. There are also for individuals whose income is in excess of 100% of the federal poverty level, up to the cap of 130%, 38% of the federal poverty level. Monthly contributions, which are not called premiums, but they look a whole lot like a health insurance premium. These are based on income and household size, and they range from around $13 to $26 per month. Failure to pay these premiums or copays doesn't result in the termination of benefits. So there's no risk of individuals losing access to healthcare services, but it does report in garnishment by the Michigan Department of Treasury from individuals' tax returns. The amount of copays varies based on the income category that individuals fall into, but it generally ranges between $1 to $3. Higher copays in the among individuals with incomes in excess of 100% of the federal poverty level may be mitigated if those individuals choose to focus on healthy behaviors, which brings us to the second of the innovations that we've observed within the Healthy Michigan Plan, which is the health risk assessment. This is a mechanism that encourages beneficiaries to complete what's called a health risk assessment, looking at various behaviors that may expose these individuals to health risks and long-term healthcare costs. Beneficiaries are able to choose one or more behaviors to address, and they work with their primary care provider to identify these behaviors, develop a plan to address them, and follow up on how that progress is going. Some examples of healthy behaviors may be weight loss through increased physical activity or better understanding of nutrition, tobacco cessation, substance use and abuse, alcohol use and abuse, follow-up and maintenance of chronic conditions like diabetes or hypertension, as well as annual immunization status for the flu vaccine. So how is this working? As of September of 2017, 210,258 health risk assessments were completed with primary care providers. Out of these, 99.1% of beneficiaries chose to either improve or maintain their behaviors, so the vast majority are taking heed when they complete this process, and more than half selected multiple behaviors. This is among individuals, however, who are completing the health risk assessment process, and that's not everyone. There are a lot of junctures for breakdown. There's been a 5% initial refusal rate when filling out a health risk assessment with an enrollment broker, and around a quarter to a third of Healthy Michigan Plan beneficiaries don't make a health plan selection, and so are auto-enrolled and may miss out on initial information on the health risk assessment process. There are reports of lack of understanding, and some of this may pertain to literacy issues or lack of clear communication about the process by which one may fill out a health risk assessment, elect a healthy behavior, and have that attested by a physician. Any issues that manifest in primary care access as well will limit the ability of individuals to complete their health risk assessment. Of the 348,236 individuals who were eligible and enrolled in the Healthy Michigan Plan for at least 11 of the 12 months in fiscal year 2016, only 66,467, that's fewer than 1 in 5, submitted a health risk assessment with an attestation date and were eligible for one of the rewards, which are either a gift card or reductions in premium contributions. Another state that did a similar health risk and healthy behavior incentive was Iowa, which also expanded Medicaid through a Section 1115 waiver. And an analysis of Iowa's program showed that in the first year, healthy activity completion rates didn't exceed 17%. So going forward, it would seem that communication is necessary to increase greater participation and buy-in. And this becomes especially important next year because effective in April 2018, based on the second of 2 waivers Michigan submitted for the Healthy Michigan Plan, beneficiaries with incomes above 100% of the federal poverty level, excluding the medically frail have to attest to a healthy behavior for them to remain in the Healthy Michigan plan. Otherwise, they would end up being moved to a private plan on the Affordable Care Act exchange. A really great recognition in the Healthy Michigan plan is that of the social determinants for health. So social determinants are factors that influence health beyond genetic, physical, or biological health factors. So these can include essential resources like safe housing and available food, economic conditions, namely poverty, education, employment, exposure to whether things in the environment, whether violence or toxins. And so all of these factors have a large amount of explanatory power when we look at why people are or are not healthy and why they either remain healthy or remain sick. Michigan's contract for Medicaid managed care organizations includes admonitions for population health management and the inclusion of the social determinants of health and data analytics so that we can better, track the social determinants of health and find out how these are influencing the health status of Medicaid enrollees. In other states that have implemented similar policies, we find that by addressing the root causes of poor health, that not only are health outcomes improved, but healthcare spending is reduced by reducing the need for costly late-term interventions for chronic health conditions, by minimizing hospitalization and unnecessary utilization of healthcare services when lower-cost alternatives can improve health. A final truly unique innovation, I suppose you would call it, in the Healthy Michigan plan, were a set of sunset mechanisms, meaning that the program would be terminated in two circumstances. One of those was if the second of the two Section 1115 waivers was not approved federally. This is no longer applicable because, as I mentioned, that waiver has been approved and is being implemented with its changes. The other is that the program will be terminated if the net costs to the state exceed net savings. And it's important to note this is not a traditional cost-benefit analysis, which is a classic policy tool. This is strictly savings. So previously we mentioned that there were savings due to the higher enhanced federal match for things like non-Medicaid mental health. So we're looking at these savings and fiscal benefits to the state and weighing them against the cost. And as you can see from the graph, as the state's required contribution increases to 10% of the program cost, that net savings gets frighteningly close to zero and could trigger an elimination of the Healthy Michigan plan without consideration for the manifest benefits that the program has provided to the state, not only the direct beneficiaries who are plan enrollees, but really the whole state. So in our new report, we have three key findings: that the Healthy Michigan plan has led to health insurance coverage for more than 650,000 of Michigan citizens and has kept insurance premiums lower for others, improving the physical, mental, financial well-being of Michigan citizens. The program also improved the state's economy by reducing uncompensated care among Michigan's hospitals and by supporting health sector job creation and retention, a healthier workforce, and increased federal spending in the state. The Medicaid program allows for substantial innovation and experimentation and variation at the state level, allowing states like Michigan to be true laboratories of democracy. While new mechanisms like the cost sharing and health risk assessments that we discussed still need refinement, Michigan has begun to use the Medicaid program to actively incentivize healthier lifestyles and responsible healthcare consumption. Michigan has also become a leader in using Medicaid to address the social determinants health approach that can improve health outcomes and reduce healthcare spending. Lastly, the many gains of the Healthy Michigan Plan may be lost because of an imprecise and poorly designed cost versus savings policy mechanism tied to the program that ignores a wide range of program benefits. At present, the Healthy Michigan Plan will be terminated if the state incurs even a single penny of net cost for the program. And with that, I'm happy to answer some questions.
We've got a few questions already, but there's still time if anybody wants to type their questions. We can pose those to Tim. So the first one, you talked about the program, how it grew 2014 to 2015, created huge growth in the Medicaid spending. What kind of enrollment growth can we expect in Healthy Michigan? Is it sustainable?
Thanks, Eric. That's a great question. I've seen a lot of concern expressed that there was a huge spike in the number of Medicaid eligible individuals in Michigan when the Healthy Michigan Plan was implemented. And excuse me, sorry, had a little interruption. There was a huge spike in since then, enrollment has stabilized around the 650,000 number that we've mentioned. As some people gain income, they go off the program, they may come back on. We do see a problem with what's called churning, where because of these fluctuations in income and employment, eligibility can vary within the year. But there hasn't been a real expansion and growth past the threshold that we met. And so it looks like there was a pent-up need or demand for the program. Now, the caveat to that is that Medicaid enrollment is highly economically contingent. And so when there are economic hardships, we see large growths in the number of Medicaid enrollees as well as Medicaid spending. Prior to the Healthy Michigan Plan and the years between 2007 to 2010, when the big three were going through bankruptcy, we saw an above average surge in Medicaid spending in Michigan, but that restabilized and dropped later as our state's economy has improved. I would also note that when you look at these economic hardships that happen during recessions, that they create social hardships and financial hardships, all of these things erode health, as does the lack of health insurance. So these are the times when people most need access to programs like the Healthy Michigan Plan. The erosion of health creates tremendous costs for Michigan, from higher insurance premiums, greater Medicaid spending, diminished labor market participation and productivity, and barriers to education and economic mobility. And so whether we pay for these costs in the Healthy Michigan Plan or we pay for them in hospital uncompensated care that gets passed off to patients and insurers, or we pay for them through Medicare when people are eventually eligible and much less healthy for having not had health insurance, we're going to pay for it one way or another.
So I understand that maybe I could not be heard for that last question. The question Tim answered was, given the high rate of growth in 2014 and 2015, whether that was expected to carry forward and is it sustainable? So thank you, Tim, for that. The next question, you mentioned some churning that's going on in enrollment. And how does that impact people, and how does that impact the finances of the program, the administration of the program?
Sure. So churning, as I mentioned, it's this sort of fluid metaphor where people churn on and off of their insurance status or move between different insurances. And this affects people with private insurance as well, if they're losing and regaining insurance. And it's an impediment to health insurance access and stability. because changing insurance status or changing from one type of insurance to another may mean that people have to change doctors, or that they have interruptions in prescriptions or interruptions in treatment that is ongoing. And while this occurs in all types of insurance, in Michigan, we see the greatest amount of churning among Medicaid eligible individuals. And in the Healthy Michigan Plan, seasonal employment, for instance, may take some working individuals over the income threshold where they would lose eligibility and need to look for another source of health insurance, only to then regain eligibility. There are no easy solutions to this problem. One that may be worth more thought I would say we can see that in Montana. So the Montana Health and Economic Livelihood Partnership, I believe it's called, the HELP program, was Montana's expansion of Medicaid. That was also done with a Section 1115 demonstration waiver. And a unique characteristic of Montana's plan is that they include a 12-month continuous eligibility period. So rather than reassessing eligibility month by month, they look at longer terms of average income for eligibility. So this restricts churning, to be sure, and some academic study has suggested that this is a viable mechanism. It does also increase costs, because people who may only, under the current program, be eligible for a portion of the year, even if that's a majority of the year, would then retain year-long eligibility. So it's another cost versus benefit calculation probably needs to be done there. And because Montana's Medicaid expansion is even newer than the Healthy Michigan Plan, we probably need more time to observe how it's working out in Montana before making any inference about how it might work in Michigan.
All right, it looks like we have one final one. So you talked about the court decision that made expansion optional for the state, and several states have chosen not to do the Medicaid expansion. Or is there anything to be learned from them? Are they creating any better market-based systems, doing anything innovative that would suggest that Medicaid expansion maybe isn't the best way to go?
That's a great question, and states often learn by looking at one another. Of the 18 states that still haven't expanded Medicaid, however, none of them have enacted any real private or public alternatives to give the working poor access to health insurance. So among the 5 states with the highest rates of people without health insurance, those are Texas, Florida, Georgia, Mississippi, and Oklahoma, I believe, none of them have expanded Medicaid. And so there's a clear correlation between expanding Medicaid and reducing the number of uninsured. And I believe almost 1 in 5 Texans, I think 19%, remain without health insurance. And that's more than triple, really almost quadruple what we have in Michigan. And likewise, there have been some attempts at the state level in places like California or Vermont to create state-level single-payer public health insurance systems or options, and those have had no enactment or success. And so as we're looking for other alternatives to innovation, at least so far, we're not really seeing any at all, let alone ones that are more successful than what we've had in Michigan with the Healthy Michigan Plan. And when we talk about private versus public, I think it's important to recognize maybe that these aren't, there's not a strict dichotomy or binary choice between the two. And really, the Healthy Michigan Plan utilizes some public resources and public rules, but it's managed and implemented by private health insurance plans who receive capitated payments from the state and work together really in partnership between the public and private entities. And so sometimes those lines get blurred, and I think the best evaluation mechanism is looking at the outcomes, which is what we've tried to do with our new report.
So the final question, will this be available afterwards? And the answer to that is yes. We have recorded the session, and in about an hour it should be, a link to it should appear on our website. It takes a little time to process everything and post it on the website. So yes, it'll be available. But that does conclude our webinar today. So thank you all for coming and for sticking around. If you have any questions, please send them to us. You can find our contact information on our website, crcmich.org. Thank you all, and enjoy the rest of your days.